last night during supper, and I can tell you he's a multiplier. I don't know if you've read some of these self-help leadership books, but there's dividers and multipliers, and I can tell you Dr. Guillem is a multiplier. Big on the team approach. It's not me, it's us. There's no silos, and he really empowers the people around him. I can tell you in cardiac surgery, as he and I were speaking earlier, the team approach is the way to go for the best outcomes, the best practices, and he encompasses that. Dr. Guillem is an attending colorectal surgeon and director of the Hereditary Colorectal Cancer Family Registry at Memorial Sloan Kettering Cancer Center in New York. His long-standing clinical interests are in the management of primary and recurrent colon, rectal, and anal cancer, and early age of onset and hereditary colorectal cancers. He was educated at NYU of Arts and Science and Yale School of Medicine and the School of Public Health, with residencies at the fellowships at Columbia Presbyterian and also at the Leahy Clinic. He is a founding member and past president of the American Collaborative Group for Inherited Colorectal Cancer, and really pioneered the first controlled prospective study to determine the risk of colorectal neoplasms in first-degree relatives of colorectal cancer patients. He also contributed significantly to advances in our current understanding of rectal cancer response to preoperative radiation therapy, chemotherapy, and neoadjuvant staging. He initiated the first prospective evaluation of PET as a tool in assessing tumor response and neoadjuvant treatment of colorectal cancers. He's co-authored more than 300 journal articles and textbook chapters. He's also been very active in numerous surgical societies and has held leadership roles in several of them in the American Society of Colon and Rectal Surgeons. He's also been the past president and board member of the FASCRS Research Foundation and member of the Executive Council. He has a long-standing interest in quality of care and served on the ASCRS Quality Assessment and Safety Committee as chair. He is currently the chair of the American College of Surgeons Pillars on Quality Assurance Committee, and is currently, I should say not currently enrolled, just passed his MBA at Brandeis. So congratulations. He's a professor at Cornell. I wish you would welcome Dr. Guillem. He's going to talk today at the Sklar lecture on advances in the management of rectal cancer. Dr. Guillem.
Morning again. Thank you. It's a big honor for me to be here, as I mentioned yesterday, and always delighted to come to different environments and learn from you as much as I hope to be able to share with you my experiences. And I've already learned a lot yesterday, last night, and this morning, so I'd like to continue that theme as we go forward. I'd just like to start off with several disclosures. First of all, this one here. I don't know if you recognize the fellow on the right-hand side there. I should have made it a little larger. That's Dean Griffin, and it's about 2013, and that's Dr. Basil Pruitt, who I had a chance to meet because my medical school days, the chair of the surgery department at that time was a cardiac surgeon, Dr. Arthur Bowie, and who did a lot of work on sepsis, and I did some work in his lab, and that's how I got to know the name Basil Pruitt and others. But so you'll cross paths with some folks, make friends, and I think that's the reason I'm here, as well as meeting Dr. Cole, who's sitting back there, way back, the originator of why I came here in the first place. I need to get a picture of you, Dr. Cole, from back then. But other disclosures, just a speakers bureau with Roche Pharmaceutical, and then, but very importantly, is that I'm speaking about something that is a multidisciplinary management, and as Dr. White pointed out, it's a team approach. So the first bias that I have here is I'm giving you a colorectal surgeon's perspective. So whatever I tell you, keep that in mind. I'm coming from the colorectal surgeon's perspective, not the medical oncology perspective, nor the radiation oncology perspective. And since I'm not going to speak about stage 4 disease, which I have in other venues, I would have listed a couple of liver surgeons on this thing, but I'm going to just speak about the local management of the primary. And for that, I have medical and radiation oncologists on this. So the outline of what I'm going to be speaking about are 4. It's preoperative chemotherapy options, the results of this total neoadjuvant therapy, otherwise known as TNT, results of non-operative management, where we're at, and some of the challenges and future directions that I think we're going to be heading into. And as I give this presentation, I'm going to be infusing in some of the progress that we've made in terms of basically imaging. What are we doing with imaging? Are we doing ultrasound, rectal ultrasound, or MRI? How are we doing the surgery? Are we doing it open, laparoscopically, or robotically? And I'll show you some of the data. And also, how are we doing the chemotherapy? Is it chemoradiation, or is it induction chemo followed by chemoradiation and then surgery? Or chemoradiation, chemo, and then surgery, which is a consolidation. And Jennifer pointed that out beforehand. So think of those are the big changes that we've seen. So whatever results I show you, you'll have to say, well, are they going to be totally applicable at another setting that may not have had the same forces going on at the same time, namely changing imaging, changing the sequence of therapy, and changing the surgical approach. So this is, Jennifer pointed out, the locally advanced rectal cancer, this is the approach, has been chemoradiation therapy combinations, followed by surgery, and then you get what's afterwards referred to as the adjuvant chemotherapy. And the Sauer paper, I recommend this. This should be like a required reading for everybody, because even the patients nowadays know the German study. This is referred to as a German study, published by a German group, but it was European. And a colleague of mine, Bruce Minsky, who's one of the fellows that I discussed before I prepared this presentation. Bruce used to be with us, now he's at MD Anderson. Wanted to do this trial back in the 90s here in this country, but there was no equipoise. There was now, the radiation oncologists and surgeons, we weren't comfortable, we were biased. We would never have not given pre-op chemoradiation, which is what the German study did. They basically flipped people with locally advanced rectal cancer defined as bulky on physical exam, and or there was a T3 penetration, and or positive nose. So when you have that kind of picture, that kind of patient, that's how we call locally advanced, you could randomize them. And that's what the German study showed. So it's a good paper to get a hold of, New England 2004, because I think it's a good design, and whatever you go into, that's a good example to look at. But that's how we were dealing with this. But the alternative treatment option is to consider giving chemoradiation followed by adjuvant chemo and then surgery. And I've mentioned the name Bruce Minsky, but I can tell you, interestingly, for you, sort of to inspire you to, when you go forth, think about something you want to do. Don't let the naysayers say, convince you not to do it. Because I remember clearly at ASCO, not ASCO, it was ACOSOG, American College of Surgical Oncology group that Sam Wells ran. It was the first collaborative group run by surgeons looking at oncology, ACOSOG. And we were there, we had some projects going. And I remember Bruce Minsky, the radiation oncologist, saying, why don't we give it all up front? And somebody says, what are you talking about, Bruce? And he's a radiation oncologist. He goes, well, I think we should just give chemoradiation and the chemo and then do the surgery. And he was laughed out of the room. People said, what are you kidding me? Bruce, you're nuts. Which patient's going to let that rectal cancer stay in them all that time? Next suggestion. Please get out of the room, Bruce, kind of thing. And he's a great buddy of mine. He was almost in tears. I said, Bruce, you did go out there a little prematurely, but you're ahead of your time. But, so I kind of said that to make him feel better, but he really was ahead of his time. He proposed something that we're now doing. This is what TNT is all about. This is the chemoradiation followed by adjuvant chemo and rectal surgery. So to phantom that patients would wait 6 months, because that's what they're waiting now. When they come to see me, and my medical oncology team and radiation oncology team is going to give them induction chemo followed by chemoradiation, I tell them roughly, they say, when will I have surgery? I say, well, about 6 months from now. That's the usual time. And they're not blown away. They trust that we know what we're doing. And I tell them, well, you're getting systemic chemo circulating through your body now. That's going to help with everything. So hold tight. We'll get to the primary surgery later. So just a teaching point there. Don't let them sway you from what deep down inside you think is right. Bruce was way ahead of it, 10 years ahead of time. So the rationale for TNT, and Jennifer alluded to this, is the earlier treatment of micrometastatic disease. Because chemoradiation, when you give it combined, there's only so much chemo you can give because of radiation toxicity. But when you give purely induction chemo, it's systemic, higher doses. Early ileostomy reversal, what that means is that if you think you get the chemoradiation, and then surgery, when you get the loop ileostomy, then it's only 3 months after that surgery before you can get rid of the loop ileostomy. You can do it sooner, but we say 3 months. If you give chemoradiation, then surgery, and then you have to get chemo afterwards, most of us would not want to get rid of the loop ileostomy until they're done with the chemo, which could be 6 months worth of that. So that's why it's shorter. Improve compliance with chemotherapy completion. What that means is around the world, the people who were proposing TNT said, hey, around the world, 40% of patients who get chemoradiation surgery and then are supposed to get the adjuvant chemo, 40% of them are not coming back for that chemotherapy. There are different reasons. they choose not to, or medical reasons. So, but 40% are not getting it. So they're saying they're getting under treatment. And then the potential to improve response to the primary tumor. I put a question mark there because that is an interesting surrogate endpoint. In other words, if you give more therapy up front before surgery, then you're likely to have more response, pathological response. And that usually portends a better overall outcome. And that's what people were trying to do. So this is some of our earlier work way back now. It goes by quickly, but this is where looking at our long-term results on people who had a PCR, which means pathological complete response. That means you did the surgery, the pathologist examined, there's nothing there. And these are those that have less than 95% response. And we're looking at overall survival and recurrence-free survival. And you can see this PCR group is definitely a much better player, behaves completely different. And all of these patients started out with similarly appearing locally advanced rectal cancer. They were all bulky, they all were T3 or N1 positive disease. So to me, this is very intriguing. How is it that some respond differently? And this, I'm not going to talk about it today, but this kind of led off to a lot of other basic science studies that were funded by the NIH. We looked at PET imaging. We thought that was the holy grail. Turned out it's not. And that still remains a question. How can you distinguish a pathological responder from a non-pathological responder? And Jennifer talked about this. You'll see that there is the clinical response that you can guess is gone, but pathology is the gold standard. So there's really nothing that allows us to see a pathological response short of taking it out, having the pathologist tell you that it's gone, and then what are you going to do? Put it back into the patient? You really can't, because that's the discussion you get in with these patients sometimes. Well, couldn't you do it beforehand? So short of that, I can't. So that therein lies the problem with management, with non-operative management. So here's the first slide I'm going to just show you. I talked about how things have evolved at our institution. So this is 2009 to 2015. It's chemotherapy alone up here. This is the percentage of the usage. Chemo radiation therapy up front, and this is induction chemo, TNT. And you can see this is where we're at now. Now it's probably been up almost 100%. So we've gone from doing the old approach, chemo radiation, surgery, and adjuvant. Now we're giving it all up front. But this is going to come down, just like anything else. Things swing back and forth, and you'll see we're going to start dropping this a bit. I didn't drink the Kool-Aid completely. I think that there is. I think the jury's still out there in terms of which approach is going to be better. There are some ongoing studies that are going to determine that. But I would say when it works beautifully on some patients. It's amazing how much response you get just with chemotherapy. So I'm going to show you the results of our TNT. And this was just published in 2018, and it's retrospective, 628 patients. We compare the outcome of TNT with chemoradiation and planned adjuvant chemotherapy, what I talked about. Those are the two comparisons. And we looked at response and determined the ability to deliver the systemic chemotherapy. In other words, how did patients do? Did they tolerate one approach better than the other? And this is very small font, I apologize, but just to point out, the p-values are here. All but one are significant. And it's comparing 5-FU chemo and those that get a chemoradiation versus TNT. And it's always showing significantly better to give it TNT, better to give it induction, at least from the perspective of the patient, symptoms. They tolerate the induction better than the chemoradiation up front. Now this is looking at response, the response to the treatment. And this is chemoradiation with planned adjuvant chemo. And this is the TNT group. And you can see the group here that had surgery within 12 months. It's 16% with chemoradiation, or 17%. And TNT, it's 18%. So they're pretty similar when you look at the group that went to surgery. Now remember, this is, I mentioned at the onset, there were multiple forces going on at this time. We were beginning to do non-operative management at the same time. So not all of the patients were going to surgery. A lot of them are going to just be observed non-operative-wise. So when you look at the lump sum of complete responders means the pathological response plus those that had a clinical complete response. So when you lump those together, yes, the group that has chemoradiation, maybe 21%. Those that have TNT, it's up to 35, 36%. So it looks, when you look at this, from this analysis, non-randomized, just retrospective, that TNT will give you more responders. So the word response will come up. That'll be probably, if you were to measure how many times I say response, that'll be one of the most common ones. And that's because that's where the field is at. It's all about looking at response, whether it's in esophageal, and rectum, breast, other cancers. So these are the current NCCN guidelines for locally advanced rectal cancer. As I said before, we're talking about T3 and 0, or any any positive node tumor, a rectal cancer, that goes down. One approach is chemoradiation, surgery, and then adjuvant. Other approach is upfront chemo, chemoradiation, and then surgery. So these are the current guidelines. They're both options that we can follow. But I'd like to propose, you probably all know Phil Collins. Anybody here heard of the name Phil Collins? Okay, good. Sometimes in the operating room I mention these names and they're like, my millennial team is like, I never heard of that. I'm like, so anyway, well, you know the song, right? We always need to hear both sides of the story. So I think in TNT, very promising, but we cannot ignore some anecdotal experiences because every one of them is important. So I'm going to tell you an anecdotal story. As I do that, I'll just want to share this perspective. I said earlier we evolved from, not evolved, but we switched from being purely ultrasound. When Doug Wong, our previous chief, when he was with us, we were doing all ultrasound. He was an expert ultrasonographer, taught all of us, and we were just doing ultrasound. But MRI, we had some experts come in from Europe and teach our team. So we're now doing tons of MRI. The institution invested in it, and there's no delay in getting these studies, and we like it. So with that expertise of MRI, I'm just going to point out, this is a pre-treatment MRI of a rectal patient in February, and it's T3 node positive. So there's the rectal cancer. These are the levators coming up. Frontal view, levators here. There's the rectum, and there's the rectal cancer. And they're calling this a T3 and positive, node positive. So that was somebody who would go on to proceed to get chemoradiation. So look at this, 6 months I said or so. This is actually 7 months in this case. They come back for their post-treatment completion of all the TNT, induction chemo followed by chemoradiation, and they're calling it now TX and 0. So I love X. What that means, with all due respect to my world-class radiological colleagues, they're just not able to call it positive or negative, and they're wisely, safely saying X. I can't call it. So, but it's an N0. They're saying the nodes are gone now, to their expert ability. So how does that compare to what I'm seeing in the office? And this is why it's multidisciplinary. You just can't rely on the radiologist calling it. And I have seen patients managed elsewhere who come back to see us for some problems, and we'll say, well, nobody scoped them in between. I say, well, no, but the MRI showed this. But you can't rely on the MRI. Nor could you say, well, the scope showed this. We would say, where's the MRI? Well, we didn't get an MRI. So you need the whole view. So this is what it looked like on my flexible sigmoidoscopy in September at the same time. It's persistent disease in the posterior quadrant. So the patient's lying on the left decubitus position. So that's front, this is back, and so there's something there. I mean, I can't prove it. I mean, it could be all fibrosis, but most of us in the audience here who deal with rectal cancer would say there's something there. So with this, we took him to the operating room. And so this is the conundrum that we're in sometimes. I'll just point that out right now. It's our inability to really know when it's clinically gone. This is obviously not gone, but there'll be other more subtle cases where we are convinced it's gone, and then pathology shows there's something there. Or we think there's nothing quite as obvious as this, but there is some persistence. We go to surgery, there's nothing there. So it's almost a flip of a coin. So this is just another view of what happened in our practice. 2009, 2015, open surgery, laparoscopy, and robotic. You can see in our world, the laparoscopy and rectal cancer management really never took off. I never did it. To me, despite my good friend Antonio Lacey in Europe, one of the leading laparoscopic rectal surgeons who said, Jose, we can do it. And I said, I'm sure we could. But to me, it was ergonomically challenging. It was just difficult for me to do that pelvic dissection well. And the learning curve with robotic instrumentation is a lot easier. You have to know what you're doing, you have to know the anatomy, and you have to be very well trained and experienced rectal surgeon to do it properly. But the instrumentation allows you to do it. And so you can see we just took off with this stuff. And I was one of the last converts to do it, but then my volume allowed me to pick up quickly. But I would be telling you, it is ergonomically and easier to do, and you have to know what you're doing, but it does facilitate, in not all, but in most cases, a good operation. So this is what we did on October. He finally came to surgery. Robotic LAR, hand-sewn coloanal, because it was very low down. We gave him a diverting loop ileostomy. Tube was 3.5 centimeters. Unfortunately, only a 10% pathological response. That's concerning. After getting induction chemo, then chemo radiation, to only see 10% response. And you know that initial figure that I show you, that 95% and less, he's not in a good curve, unfortunately. And this is having gotten chemo first, then chemo radiation. So this case gives me pause. It makes me wonder, maybe chemo radiation, hitting it up front with double therapy, multimodality therapy, and then chemo, and then surgery would have been a better option in this case. And that's another problem that we face around the world, is what is the right sequence for this? How do we choose these people? Even though you love TNT, how do you flip the sequence around? How do you tailor it to the individual patient? I'm sure that goes true for all your other disciplines, is how do we tailor it better for the individual patient? But margins were involved, so I felt good. In fact, just for the residents and students, I'm sure you know, when you get the path report, first thing I look at are the margins. I say, oh my God, margins are good, because that's what we can control. That's how I measure how I did it. So that's the first thing I look for. That's good. I guess that you could say he wouldn't be showing this case if he had a positive margin, probably. But no, I would. I would share, because I would explain the difficulties with that case. But the negative margins, it was close to the bottom, but we did a hand sewn, we got it out. And then the other thing that's concerning, besides the 10% response, are the mutations that he had, and that he was microsatellite stable. Because microsatellite stability, not part of this talk, but that gets into the whole Lynch syndrome, and it gets into responsiveness to therapy. But if you have someone that's stable, you'd rather have your patient have an MSI, microsatellite instability. They're going to have more options down the line than someone who has stability. It's just responsiveness. So summary about TNT, as I summarize this part of the talk, I think it facilitates compliance with systemic chemo and may limit the duration of the ileostomy, but it's not proven of survival benefit right now. It hasn't been proven yet. It works well in our hands and we like it, but there's no evidence. And at least in this patient that I show you, it looks like it didn't help him too much when he only had a 10% pathological response, even though he got it all up front. The PCR rates may not be any better than with pre-op chemotherapy alone. TNT may be overtreating earlier stage. This is what my colleagues up in Boston will say, Jose, these T3 and 0, you're giving them way too much therapy. Induction chemo with FOLFOX, follow-up chemo radiation therapy. And some of these patients have combined and said later, Jose, surgery was a piece of cake. But that chemo, my hands are still, my feet, I can't, I'm not talking about a concert pianist, I'm talking about just average day folks who are challenged with their dexterity or lack thereof. TNT may not improve outcomes in patients with progressive disease while on induction chemo and delayed commencement of chemo radiation therapy. And I've seen those. You could argue this patient might have had that because, maybe he did rise a little bit. Maybe there was more response by the time he was getting his chemo radiation therapy. These cancer cells, these resistant cells might have been revving up. These are things we don't know. We don't really understand. This is like very basic questions that the basic scientists are trying to address. So prospective studies are needed to identify those best suited for TNT. So this is a trial that Jennifer referred to as the OPRA, Organ Preservation, and led by my colleague Garcia Aguilar at Memorial, but it's a multi-center trial looking at induction, and then the other one is consolidation. So induction is chemo followed by chemo radiation. Consolidation is chemo radiation followed by chemo. And then there's a restaging. And no significant response, you're going to total mesorectal excision, which is surgery. Those that have a very significant response, there's the word response again, right, are looking at possibly going down this watch and wait approach, which is non-operative management. And I'm going to go into that in a moment. This is the German study. Rodell, who's a friend, he was one of the fellows that I discussed with early on, Klaus Rodell. He ran the German study, but in the good old German system, he was not the first author, it was the professor. His boss was the first author. And Klaus, of course, in the European system, he knew he'd wait his moment, and now he's going to be the first author in all these new studies. Klaus is a great guy, and this is the German study, the newer version, looking at adding, this is without going too much into the details, it's just all of these studies are comparing chemo, induction chemo versus chemo radiation and then chemo. That's the question. Induction And then also they have an arm which includes non-operative management. So a lot of these are going to have non-operative management being an option for the patients. This is the Rapido study that now is completed, and I think they're going to present it at ASCO in June, looking at short course versus long course chemoradiation therapy. This is the Prospect study. This actually came out of our institution. Deborah Schrag was a medical oncologist with us. That we did an initial pilot study in this, and then now she's up in Boston and running this. And what this is looking at is the question is, with upper rectal cancers, can you just give chemo and obviate and skip the need for radiation therapy? That's the question that's being addressed here. And this is the recent TNT trial that's being run in this country by And what's interesting about this, they don't have a non-operative management approach on this arm, and this may challenge their accrual, because unfortunately the patient population out there now, they're looking to, wait, what about non-operative management? This is interesting how it trickles down to the consumer. They're coming to me saying, I'd rather not have surgery. And I'm like, well, I'm a surgeon. That's what I do first and foremost. But we can discuss non-operative management, how it may be an option that you may choose to pursue, but it's not standard of care. And that's the bottom line at the end of the day. On the standard of care is this, and this. Non-op is an option that you may want to pursue. But in this TNT approach, what they're going to have is rolling biologics. So it is an interesting design that came out of the breast experience. People realize that you design a study now, by the time it's rolling, there's going to be a new biologic coming out. You're going to say, gee, now I've got to rewrite that whole thing. And so this allows for introduction and accumulation of information without having to stop the study and terminate it. So it's an interesting design that's, again, started out in the breast world. So how do we manage the clinical complete responders? And what is the complete clinical response versus pathological response? So this is PCR. It can range from 10 to 44% depending on which study you look at, and depending how long you wait. If you wait a longer time, of course, you're going to have more effect. It's not quite like anal squamous cancer, where we know that's about 80% pathological response. And if you wait longer, there is more and more response. The rectal cancer may plateau earlier. Oncological outcome for PCR patients is markedly better, and that's the first slide that I show you folks, some of our data, and others have corroborated that. If you have a complete pathological response, those patients seem to do great, both locally and distantly. So is surgical resection necessary for patients with a complete clinical response? So this is what the blanching spot that Jennifer pointed out earlier. You look in there and you don't see anything. And it's remarkable. Even on induction chemo, I've seen that. It looks like it's gone. And you get an MRI, it looks like it's gone. You put your scope up there and you push it, and it's not tethered, there's no ledge, there's nothing. It's just supple. It expands beautifully. That's pretty clinically gone. But there could be disease in the wall, there could be disease in the lymph nodes. And that's, again, what we just don't know. So, but this is what led, and people, Angelita Habrigama from Sao Paulo, Brazil, was the pioneer of this approach. And she started to recognize that there were people. So the rest of the world has now taken off on this. So managing the clinical complete response non-operatively, why should we do this? Okay, and because we can spare someone an operation. That's one reason, one very important reason. But I like to use the analogy of Mount Everest. I don't know if any of you climbed Mount Everest yet. You did? Fantastic. Wow. I read this phenomenal book, and I toyed with the idea for a little while, Into Thin Air. I don't know if anybody read that one. It's a great book, right? And my son Nick was about this tall. We were at the beach that summer, and I remember reading the paperback within the water, and Nick in one hand, I let him, and I'm always one of these doting parents, but with that book and that story, it was like Nick was going in, his mom was yelling at him, "What are you doing?" So this is a riveting book. I would highly recommend it for you. But I caught the bug, and I thought Mount Everest, and I read everything about it, and George Mallory and all those things. But there is some interest in this and how it relates to non-operative management. So when George Mallory was asked why he wanted to climb Mount Everest, this is back in the 1920s, his response was, because it is there. Right? So this is the 1920s, and he perished, unfortunately, at that time up there. He got very close, I think 800 meters from the summit. But when the body was found near the top of Mount Everest, 75 years later, Sir Edmund Hillary, who was knighted, because along with Tenzing Norgay were the first to actually summit Mount Everest, was asked if he thought Mallory actually made it to the top of Mount Everest or died getting there. So that still remains a huge question. The British perseverate over this a lot. It's a big question, what happened? It's a beautifully romantic story. But he said, no one knows for sure. However, it is one thing to say you have been to the top of Mount Everest. It is another to say you have been there and back. It's kind of bold, but he said this. But it is interesting, and it is true. And I think, similarly, managing rectal cancer with a complete response, I think it is one thing to say you have spared someone an operation. It is another to say you have spared them an operation indefinitely without worsening their quality of life nor affecting their survival. So I think that's what we have to keep in mind. It's a challenge on operative management. So this is a sort of a meta-analysis of world literature as of 18 in the Lancet. 880 clinical complete responders did not undergo surgery, median follow-up of 3.3 years. So it's a good, but it's not too long, only 3.3 years. Very general inclusion criteria because, again, it is multi-institutional, it's retrospective, and different entry criteria. So you always have to know what you put in is what you get out. So they're getting variability in already. 25% had local regrowth, most within 2 years. I think that is true. If you pursue the non-operative management, most will tend to fail early. Those that go a little longer may be more promising, but that's the price to pay. When patients say, well, I'm going to try it. And they say, well, you can try it and you'll fail within 2 years. If you don't, you're going to. But if you fail, then that's a real disaster when you could have been spared with an operation. 97% of regrowth occurs within the valve wall, and 8% are going to occur distantly. 98 and 94% compliance with radiation therapy, chemotherapy, respectively, meaning people who wanted to go down this path actually did agree and did stick to the treatment. The 5-year survival, you can see with a wide and weight approach, 85 overall, 94% disease-specific. So this is all good. This is very promising. Watch and wait is a viable alternative to resection in clinical complete responder patients. Most recurrences occur within 2 years. That's all true. However, the unresolved dilemma is, do patients with a local failure following a watch and wait approach fare worse than those who proceed to surgery in the first place? And that's really what that comes down to when you're in the office. You got to mention this. I don't know. We don't know this. So we've been doing this retrospectively. We've published a handful of papers over the years, and now we're doing this prospective study, which will shed some information. But this is a poster that summarizes. Now it's published, but Josh Smith, our most junior colleague, and I'm going to go through each of these slides just to go into a little more data. That's the January 06 through January of 2015, 113 cases for complete response. So you can see how they divvy up into those that had a sustained clinical response versus those that had a regrowth. But at 5 years, 79% were able to preserve their rectum. So in these highly selected patients, all retrospective, who happen to have this kind of view, where we think it's totally gone, 80%, you could say, 4 out of 5 will have rectal preservation. When it regrows, you can see it, and you do the operation. But 91 of those sustained pelvic control after salvage surgery for local regrowth. So all this is good. So if you go down, you can tell the patient 80% of the time you will be able to preserve your rectum. When it does regrow, I can take care of 91% of the time. 9 out of 10 patients, we can salvage this for you. But the oncological outcomes do raise concern, because when you look at the watch and wait approach versus those that go to surgery and have a PCR, meaning you took them to surgery and you cut it out and there was nothing there, which is the group we should be comparing to, you can see that although the 5-year overall survival, disease-specific survival are close, there is a difference in overall survival. Not statistically significant different yet, but with time and bigger numbers, my bias on this is that we will see a difference. That's my bias, but it's not proven yet. What has been shown thus far is that the distant metastasis rate in the watch and wait approach versus those that go to surgery and have a pathological response is different. So these are the numbers. Watch and wait approach, 8% distant metastases versus only 4% in the complete pathological response. That's twice the amount. And when the local regrowth occurs, it's 36%. When there's no local regrowth, there's only, 2%, 1% there. It's very low. So practically speaking, what you have to tell the patients is, if you want to pursue this, we can go down this path. You might be fine if you make it out to 2 years. If not, we can salvage you. But if there is local regrowth, your chances of having a distant metastases is going to be significant, twice as high as if you had gone ahead with your surgery. So that's a big concern. And this paper that just came out in JAMA Oncology this winter basically adds a word of caution to this whole momentum of non-operative management. That yes, you can do it, but this is with more follow-up, more mature follow-up, bigger numbers. This is what we have to take note of. I just want to mention, getting close to wrapping up, another thing that I think is of interest. This is, and I attribute to one of my many mentors, Mary Brennan, who's the chair when I had this grant. We were funded to look at assessment response of PET imaging. And Mary Brennan used to say, if you have anything prospective, make sure you milk it for everything. Get all the specimens, collect it, and analyze it. And had a phenomenal, assertive, talented, smart German resident who contacted me, I guess through the papers, called me up, and with his very good English, emailing back and forth. And I called him up and said, Tobias, let's talk about this. And he basically was proposing working with us. He had all the German dollars available to him. And I said, sight unseen. I said, all right, Tobias, I think we can work together. So he came over. Perfect timing. He took a lot of our data that we had and collected, but he just, in this beautiful Germanic organized way, just crunched a bunch of nice papers, one of which was to address this question, which is that we wanted to study in about 100 patients who all got chemo, radiation, and then surgery, and then adjuvant chemo afterwards. This is the old system, the old model. We wanted to know what was the distribution of lymph nodes. Because when we consider radiation therapy, that's the rectal cancer. We're talking about the rectum, the mesorectum, and we've got the IMA. This is, for those of you who know the history of Miles, or the zone of upward spread, right? That's what Miles talked about. This is the IMA. Then you've got your sigmoidal vessels. And the questions are, do we cut here surgically? Do we cut here? Do we cut above the eye, take off of the left colic at the base of the IMA? So just of surgical interest, we did this. And this is what we had the collaboration, the teamwork of Jin Rushia, who was a fellow at the time, but now she's a professor in pathology with us. And she laboriously, we convinced her, her boss at the time was David Klimstra, who's not the chair of pathology. So it was a great teamwork. And she, on all these specimens that we gave her, she basically did a whole mound mapping. Others like Phil Cork in Europe have done whole mound mapping of the mesorectum. She did the entire colon just to see where the lymph nodes are positive or not. And these are the results. This is Tobias. So mesorectal lymph nodes, these are the nodes around the rectum. As you'd expect, 80% of them are involved. Those are the more likely to be involved. But to our surprise is that these pericolic and apical up here, pericolic up here, most concerning to me are the pericolic, are maybe 10% of the time involved. So if you're doing a non-operative management on these patients and we're following them here, with imaging, with MRI, this is beyond the zone of MRI. We're not zooming in on this area, imaging-wise. First of all. Second of all, from the radiation oncology perspective, Bruce Minsky said, wow, Jose, let me look at this. So he put this line here for us. That's the superior border of the radiation fold. So radiation therapy doesn't get to these at all. It's not surprising, it doesn't even get to these lesions. So it basically is about the surgical approach, where you will transect. And I can tell you now that I'm doing a lot of this robotically, I'm having to remind myself of this data, and we're going to revisit it now, because and laparoscopically, you must encounter the same thing. When you mobilize the sigmoid colon, you get it up in the air, and you're looking at it from this side, where do you transect? You might do, like we always do now robotically, we always get a high IMA ligation. And we come down, and so we could cut here, or you can cut here. So that, I would say you probably want to cut up here uniformly and get all, and then bring this down to the anastomosis. But I can tell you, this area here this is not being addressed right now. We're not thinking about that, and I think this old data is worthwhile keeping in mind. So, concerns about non-operative management, I personally think, is it going to flip the frequency of failures? Right now, we've got more distant than local failures, but with this non-operative management, are we going to increase local more than distant now? Is that a possibility? Does it decrease the rate of sphincter preservation in patients requiring early salvage surgery? That's something that you need to tell them, because you might have it at 5 centimeters, the muscle's only 2 centimeters, you've got 3 centimeters of wiggle room to take it out and connect. But as you're watching this, and this starts coming back, it's going to grow this way, but also downward. So you can have your margin is going to be diminishing as you're watching. And I think biologically, have we selected out a clone of radiation-resistant cells too small to visualize in the mesorectum, yet highly virulent and capable of distal metastases and death? And maybe that's why we're seeing this doubling of distal metastases when you have a local regrowth. That you might eradicate the majority of the cancer cells, but the few clones or 2 that are remaining would make sense, right? To be the most resistant, most virulent. So is radiation therapy targeting all possibly involved regional lymph nodes and lateral lymph nodes? That's the picture that I just showed you. So the unanswered questions, there are many, but I just highlight a few. How do we improve pre-therapy imaging? That's the biggest thing, I think. I used to have an old slide from St. Mark's Hospital where they didn't talk about imaging, but they talked about our inability to tell within simile stage primaries which are positive or negative lymph nodes. We're still in the same situation. How do we identify resistance early on? In other words, you can start therapy A, and if it's not working, how can we be sure that early assessment is predictive of what the late assessment will be, so you can jump ship? You can say, hey, it's not working. Let's go to option B rather than torture this person with all of this therapy. We can go to something else early. The other part is the durability of rectal cancer and lymph node metastasis response, because the fact that we see it gone now, like Jennifer pointed out, we think it's gone. There's just a little blemish there. How long is that going to stay as such, right? We don't know how the durability of this is. And then, very important to me, and I pointed this out at ASCO GI 5 years ago, so they thought I was a little nuts. I asked the medical oncologist, is there a persistent linear response to preoperative CNT and relapse-free survival at the individual patient level? Because we can push PCR, and that's great. And we think that the more PCR we get at a population level, that's going to translate into an improvement in survival. That's not been shown yet. When you look at individual data sets and you separate the groups into PCR versus non-PCR, you can say, yes, the PCRs do better than non-PCR. But if you were to introduce a new therapy and you got more PCRs, is that going to bump everybody up? Not been shown yet. And then how do we diminish local and distant failure while preserving anorectal bladder and sexual function in the least toxic manner? Because I think that's really the goal. How do we do this in the least toxic manner? I was in Japan speaking on this topic about it last month, and this is from The Wizard of Oz, because my daughter is into film. She's a editor, sort of thing. So I was asking Vicki, I want to show that we're in a situation where there's so many options to manage our patients that it's a bit of we're in uncertainty. And I just want to show how the patient would feel, and she says, well, the Wizard of Oz type, when she's there and all the monkeys are flying around. So this is the Wizard of Oz in Japanese, but Dorothy, I think, right, in the middle. I think that's how it is for us and the patients, with so many options. They're all good ones, but it's all about tailoring it to the patient. And you have to decide on the risk that you are going to take, and the patient's going to take the risk. So I finished on my last slide, my mentor in colorectal, Mike Weidenheimer, great friends of Whitney Box and others from this institution, who said the doctor does all the calculations and the patient takes all the risk. So keep that in mind as you go forward. So thank you again for this honor, and I'd be delighted to answer any questions.
but you tend to aim for a window to do the surgery because it's safer, it's easier, and all those types of things. Now you're talking about 2 years, 3 years out, operating on those patients that have had chemoradiation. What are those procedures like?
Great question. And that's something that, again, I wasn't the focus of this talk, but I do bring that up as a challenge because, as you know, we all know from the failed anal squamous cancers, the NIGRA protocol, those patients, when they fail, and it's more than 6 months, we actually published on this, we looked at a study. David Chestnut, who's now at Sinai, our fellow, looked at this, looked at comparing a salvage APR in somebody who had chemoradiation for anal squamous cancer, and he controlled those that got a flap versus those that didn't get a flap. A rectus abdominis flap for the junior residents. The plastic surgeons can take the abdominal wall and skin and muscle and fat and flip it to cover the perineum. And he compared how do they do better. And those that get a flap tend to fail, tend to have less breakdown of the wound. So when I have a non-operative management patient who fails, who now needs an APR, I tell them, way before at the beginning, I said, look, you need a robotic APR. But if you don't want to have this surgery now, I understand. The robotic APR, you'll be home in 3 days. You could go home in 2 days, but usually it's the colostomy training that keeps you the 3rd day there because it's so minimally invasively. It's a quick in and out, no incisions, just a port, and the only opening they get is a colostomy, as we know. But they say, no, I just got down this non-operative management. I say, well, I need to let you know that if you do go down this non-operative management mode and you do fail in the future, and we do have to do an abdominal perineal resection, which you will need because you need it now. If you need it, you're going to have a much bigger operation, from no incisions to a big incision with half your abdominal wall gone to the bottom. So I think you're absolutely right. It is a much more challenging, more fibrotic, difficult surgery, harder to heal. That's something that has to be introduced, yeah.
What subset of patients do you see that are opting for non-operative therapy? Do you see the young, the old, or just a mixture in between?
Yeah, it's a mixture. Again, my team, my nurses, they can smell it. They're just great at telling this, and they're very emotional and passionate, as we should be. And one, Stephanie, is the most senior of the group. She's only 35, she's the most senior. And she's now an NP. So that I hired, sight unseen, somebody hired her for me. They said, the best hire you ever had. I said, I'd really like to meet her, but they hired her. Best thing that, I agree to that. So Stephanie has often said, let me go and talk to them. And she has gone back and spoken to them, and they still don't want it. But they come back, some of them, and it's a range. I have one lady, she's so thrilled she underwent the surgery. She had everything completely gone. And what I had to tell the patient, and I used to tell them this before we went non-operative management, my message to them pre-op when I saw nothing there, I would tell them, listen, I need to tell you that the potential discussion we might have after surgery. And they say, what is that? So the potential discussion might be that we will have this discussion about the good news, bad news scenario. What is that? Well, is that the good news would be that I would say, Mrs. Jones, great news, it's totally gone. There was nothing in your specimen. And the bad news, now you've had a complication, or worse. And that's something that's sobering for the family, the patient to understand, because I knew that 20% were going to be gone. And even though I told them, if you're in that group that has it's completely gone, you're really going to have a great outcome. They still have to understand. People would say, why didn't you do the surgery again? There was nothing there. And I've told them this could be misconstrued in court. Somebody could say, the good Dr. Guillem took this thing out and there's nothing there. Ladies and gentlemen, let's look at the path report. There's nothing there. Why did he do it, right? So it is, I find young people with children tend to think about long-term. I think I'm finding, if you ask me male versus female, I think the females we were discussing last night are a lot wiser than us gentlemen. I think, percentage-wise, I would say more wisdom there. Yeah. They tend to think the mother and the matriarch here, somebody's got to be around here to take care of this family. So they say, I'm going to do the surgery. I got to do everything possible to make sure that I'm here. And even if it's, let's do that. So it's a range. Yes?
Jose has a very nice presentation, very thorough, very involved. I want to thank you for mentioning that being cautious about who you watch, because I think that even in the best of hands with high compliance rate, in other words, following these patients carefully, your failure rate is still significant. And in our population where we have compliance as a major issue, I think that becomes more of an issue. We recently took care of a gentleman that we wait and watch for 2 years. and he was lost to follow despite multiple callbacks and letters sent out. And when he came back, he presented with a very locally advanced rectal cancer. We were prepared to do a pelvic exent, but by the time we finished the dissection, we realized it was involving the right pelvic side wall. So this gentleman could have been salvaged or saved 2 years ago. Now it's going to have this recurrence that cannot be resected. That's going to be a horrible recurrence, as you can imagine. So I think that the compliance rate of the population you're dealing with also have to be taken into account when you consider the Weight Watch. And I applaud you for all the work that you've done advancing this field so that we can understand and benefit from this.
Well, thank you for those comments, and I agree completely with you. That's an excellent point that you raised. I think you have to understand the likelihood of them coming back. Same thing comes up with surveillance colonoscopies. Whether you do an extended procedure or not, you have to consider: is this the only opportunity we're going to have to help this patient? Because they're not coming back. Right. So you have to work that into the equation. But it's an excellent point.
I just do you have a comment about the cost? Because yesterday your talk, which I enjoyed thoroughly as well, comparing the extracorporeal resection, old-fashioned staplers versus hybrid versus complete laparoscopic. I think, and I'm asking you this more for the students and residents, I don't think that any of them or us realize oftentimes the expense of chemotherapy in order to deliver the care.
So your question, the first part, I didn't hear the first
part.
Well,
the question is basically, what is the expense of chemotherapy? Do they get more in this period where you're doing all total chemo radiation, or is it exactly the same?
Well, that's a great question. I have to check with the specifics of that dosage and with my medical oncology colleagues on that. I believe it's not intended to increase the doses as much as just the completion of it. Because when they go chemo, radiation, surgery, and adjuvant, like I said, 40% are not getting it. This way, we have more of a captive audience. I don't think the intent was to give you longer chemo. There are studies that have come out subsequent to that we've gone from 8 cycles of FOLFOX now to 6 cycles of FOLFOX, and perhaps even going to diminish it even further. Because they're getting the same, no pun intended, bang for the buck. They're getting the same degree of pathological response with fewer cycles of FOLFOX than they were before. So I've seen it decrease from the studies that they've done from 8 to 6. And I'm glad they're going in that direction. As I said, minimize toxicity, yet continue with the same outcome.
You use CT scans, MRIs, and endoscopy, but you don't ever use PET scans?
Mm-hmm. Correct. Well, we put the nail in that coffin. That was a study. That's what we wrote a couple of papers on that. They were prospectively done, and we were funded. Not New England Journal of Medicine studies because they were negative studies. Basically, it didn't show. I was hoping that it would show. And that's the way I convinced the NIH that it still remains a great question. How do you figure out who's got a complete pathological, to the best of your ability, without removing it? So that was the goal of that study. But it didn't PET nor CT. The problem with the PET in the pelvis, particularly, is that you've got a very powerful signal from the bladder. And the people in the esophageal world had better results. The Germans did really nice work with that. Unfortunately, the pelvis is too much activity. I think that I'd like to revisit that. That study that we did was looking at PET 6 to 8 weeks after completion of chemo radiation therapy before surgery. And that was the question. At that moment, when you've got the patient in your office, can you use the PET or CT to help you figure out where is it gone or not gone? And then we went to surgery, so we had good design with good numbers and all power analysis. But what you could do, and there are some people looking at this, is if you choose to go down to non-op management, do some serial PET imaging. And if you follow them long enough, the inflammation from the radiation chemo will go away. So that signal will disappear. And maybe it's possible that with time, if you start seeing it, you follow them, disappears, you're watching them, and then hopefully you'd pick up a little signal rise before you see it clinically. And then you might be able to salvage more and maybe not wait for that big pelvic recurrence to come back. That is another way of looking at it.
Dr. Guillem, we have a little token of appreciation for you coming to Shreveport. Thank you so much.
Thank you.
Come back.
Awesome.
Thank you so much.
Thank you so much. My pleasure. Thank you all. Wow.